The mechanism of action for regorafenib is quite similar to the mechanism of action of sorafenib, and the drugs are very similar, and there's only one fluor atom which is different between sorafenib and regorafenib. But with that, regorafenib has a much broader spectrum of activity, and there are more kinases and pathways that are inhibited. So at the moment, we think there are three main mode of actions. One would be on the tumor cell itself, on the microenvironment, and finally also it has some anti-angiogenic activity by inhibiting VEGF receptor pathways, for example. And all these three together most likely led to the success we saw in the recent trials with regorafenib, also in patients with HCC. And with that, we had the first clinical trial that was really successful in HCC in second line.
As the first positive phase 3 study in advanced liver cancer, whether first or second line, since sorafenib's approval, this is a hallmark study. The improvement in overall survival looks to be the similar magnitude that we saw in sorafenib. And while you could argue this is not a cure, it is an incremental advance. We have gone from having only sorafenib, and when patients progress on sorafenib, really having limited options outside of clinical trials, to now having a drug that has been shown definitively to improve survival. We saw a 3-month median improvement with sorafenib. Now we're seeing a median 3-month improvement with regorafenib for patients who get both drugs. So I think we're going to continue to see an improvement in the natural history of advanced liver cancer. It also needs to send the message that there is a plan for patients, that as patients progress beyond chemoembolization, we now have more options for management and that continuum of systemic therapy. I think one of the challenges over the past decade in only having one systemic therapy for the treatment of advanced liver cancer, even though it's been proven to improve overall survival, has been the perception that systemic treatment doesn't work for this disease. And that maybe has led to a bias of relying more on local regional therapy. Probably longer than it is proven to be of benefit. I think now with the RESORCE data, with the availability of 2 systemic agents that individually have been shown to improve survival, we need to keep that in mind so that patients are candidates to get treatment. If patients receive chemoembolization beyond progression from that approach, then we might miss the window of opportunity to give patients effective systemic management. There's no doubt that chemoembolization helps patients with liver-confined disease, but again, it's not a cure. Patients will progress beyond that. And every time a chemoembolization is done, no matter how selective it is, it does induce some damage to the liver. The most frequent side effects are liver-related side effects. And if we taste beyond progression to the point that a patient experiences significant liver dysfunction or decline in performance status, they may never be a candidate for not only first-line therapy, but then maybe even second-line therapy.
I think these findings will have an impact on our daily clinical practice, because so far we only had one systemic therapy available, one line of therapy with sorafenib, in which we used in general for around 4 to 5 months at best in our patients. Now we have an option for patients for second-line therapy, and we have an impressive overall survival in this group of more than 10 months. Which means we have now to think even more about the points we have discussed before. For how long should we do local therapies, for example, TACE, and when would be the best time point to switch to systemic therapy, now having 2 lines of therapy available, of course, in selected patients that tolerate these multi-tyrosine kinase inhibitor. So saying that, these drugs are probably not drugs which we can use in all of our patients. Yeah, some patients just do not tolerate these tyrosine kinase inhibitors, but those that do tolerate them, they have really 2 options now available with an if you look at the overall survival, or if you look at the survival in the RESORCE data from patients from the beginning of sorafenib, and then the median overall survival, it was more than 20 months, which is really a very good outcome data.